Welcome back. I'm Dr. Michelle Aristizabal, and I'm an obstetrician in Scottsdale, Arizona. As a doctor who takes care of a lot of women looking for low intervention or natural birth, I also see a lot of women who've had a previous C-section, and they're looking for a chance at a vaginal delivery or a VBAC. I've cared for hundreds of women in this situation, and I have a VBAC success rate of over 85%. When I see these women for the first time, a lot of times they'll come to me with some anxiety because of a lot of inaccuracies that they've been told by previous providers. So today, let's break down some really common VBAC myths and help set the record straight so that you can make an informed decision about whether or not VBAC is right for you. But before we get started, I want to define some terms. So first, what is VBAC? VBAC stands for vaginal birth after cesarean. And you'll also hear people use kind of simultaneously a term called TOLAC, which stands for trial of labor after cesarean. So when a woman comes into labor, if she's had a previous C-section, she's considered a TOLAC. So she's having that trial of labor, and then if she delivers vaginally, that's considered a successful VBAC. Alternatively, a woman may plan for an elective repeat C-section. That means that ideally we're going to perform a C-section for her before she labors because that's the mode of delivery she would prefer. If a woman is attempting a TOLAC and ends up having a C-section because of some sort of complication during the delivery, then that would be considered an emergency repeat C-section rather than an elective repeat C-section. One more term I want to define is uterine rupture. The main risk associated with a TOLAC is that the uterine wall could open up, usually related to some sort of weakness in the scar from the previous C-section. Now, this can happen to women who haven't had a C-section before, but it is much, much more common in patients who've had prior uterine surgery. The quoted risk that we see pretty consistently in the literature is about 0.5%, or 1 in 200 women who experience a uterine rupture. And that's really the main risk that we're worrying about and the main thing that we're counseling a patient about when they're considering having a VBAC. And this leads right into our first VBAC myth, that a VBAC is too dangerous because of this risk of uterine rupture. And if a woman's had a previous C-section, she should always have C-sections for all of her subsequent deliveries. However, what this type of thinking often overlooks is that repeat C-sections also have risks. And what most of my patients want to know is not what's the risk of uterine rupture, but what is the risk or the chance that something bad happens to them or their baby during a TOLAC, what we call significant morbidity or mortality. Well, when we look at women who've had a previous C-section, the risk of significant morbidity and mortality during a TOLAC is actually comparable to the risk of significant morbidity and mortality during an elective repeat C-section. And thankfully for both modes of delivery, that risk is relatively low, less than 1 in 1,000. Despite this, patients will often be told that their doctors just don't perform VBACs or that their hospitals even have a policy prohibiting VBACs. However, no one can force you to have a repeat C-section. And if your doctor or hospital is trying to do that, then they're not really following evidence-based medicine and they're not following ACOG guidelines, which clearly state that women should be given the option for a TOLAC. Another inaccuracy that I frequently hear from my VBAC patients is that they have a high risk of uterine rupture, anywhere from 1 to 2%. This is just blatantly incorrect information that I hear repeated far too many times. We have many, many studies demonstrating that 1 in 200 risk of uterine rupture that I quoted to you previously. And there's very few studies that show any higher rate of rupture, and there are even some studies that show a lower rate of rupture. So we're pretty confident when we counsel patients using that number. The only exception to this would be if you were induced during your VBAC. There are some studies that show a slightly higher rate of rupture, but still not more than 1%. The other exception would be if you have a short interval pregnancy. That would mean less than 18 months from one delivery to the next. There are studies that have demonstrated a higher rate of rupture, even around 1 to 2% in that situation. And there are studies that show that for patients who've had a classical C-section, meaning an up and down uterine incision, that shows a significantly higher rate of rupture, up to 5%. So most providers would consider a classical cesarean a contraindication for VBAC because that rate they consider significant enough. The next inaccuracy that patients are often told is that if their uterus were to rupture in labor, that there's up to a 50% chance that their baby could die. This is something that's so difficult to talk about because obviously the loss of a baby during labor is the most devastating situation that a parent can experience and something no care provider ever wants to face. However, exaggerating the rate of this tragic outcome is unethical. Unfortunately, I have seen this rate quoted on hospital TOLAC consent forms, and I've heard physicians quote it to their patients, even though it's blatantly false. In the United States, the highest rate of uterine rupture-related perinatal mortality that has been demonstrated is 6.2%, and that includes preterm deliveries. When only term births are considered, that risk goes down to 2.8%, which means if you assume a uterine rupture rate of 0.7%, which would be on the higher end, that the chance that a baby would be lost during a VBAC is less than 1 in 5,000. If your previous C-section was for failure to progress, then you may hear the fourth most common VBAC lie, which is that the chance of a successful VBAC when the patient's previous delivery was for failure to progress is very low, especially if your baby is the same size or bigger than your last baby. However, VBAC success rates are actually very good despite a history of failure to progress. Somewhere between 60 to 80% of TOLAC patients will deliver vaginally, which is comparable to the C-section rate for the general population who haven't had a previous C-section. And depending upon your initial provider's C-section rate and your current provider's successful VBAC rate, you may actually have a lower chance of a C-section during your TOLAC than you had during your first labor. While failure to progress is considered a recurring indication for cesarean, most failure to progress is specific to the circumstances of your previous delivery, which are not necessarily recurring, such as indication, malposition, limited mobility or pushing positions, or just an impatient provider. The most common situation patients are told that they are a bad candidate for VBAC is if they had failure to descend, meaning they got to fully dilated or close to it, but their baby didn't come down into the pelvis or they couldn't push their baby out. However, in my experience, these patients often do the best in their TOLAC. They labor quickly, like a second-time mom, and if we give them better support for their delivery process, they typically will deliver easily. On a side note, some doctors will use a VBAC calculator to estimate a patient's chance of success. These calculators notoriously underestimate a patient's chance of success and will pretty uniformly tell a patient who had failure to descend or failure to progress in a later stage of labor that they have a low chance of success, typically less than 70%. However, ACOG specifically states that an estimated success rate of less than 70% is not a contraindication to VBAC. Another lie or inaccuracy that patients are often told is that they can try to have a VBAC, but if they aren't in labor by 39, 40, or 41 weeks, that they need to have a C-section scheduled. This is another one of those really common things that patients are told that have no grounds in either ACOG's guideline or medical advice. Having a previous cesarean does not make it any riskier to go back past your due date than it does for any other patient. Delivery timing to prevent increasing risk of pregnancy complications and stillbirth should be an individualized decision between you and your doctor, not some blanket inflexible policy. I have many patients who prefer delivery between 39 and 40 weeks based on their individual risk factors. And I also have many patients who feel comfortable going to 41 or 42 weeks, especially if they're low risk otherwise. The reason I think most doctors schedule a cesarean just in case is because they're not actually a VBAC supportive provider, and they're betting their patient will not labor, and they get to be the good sport who let them try, but they still get to do the section they prefer to do. These are often the same doctors who repeat lie number 6, that a patient can't be induced if they've had a previous C-section. So if a patient does need to be delivered before they labor, typically earlier than their due date, they are often told that they cannot be induced and that instead they must have a C-section. This is just another myth. Multiple studies have demonstrated the safety of induction in TOLAC, and while some show slightly higher rupture rates of somewhere between 0.7 to 1%, this is not significantly higher, and many studies show no increased risk of rupture. Some studies do show a slightly lower chance of VBAC success, somewhere between 60 to 70%, but again, this is not significantly lower than other TOLAC patients and is certainly not a reason to deny a patient a TOLAC. Another VBAC lie that patients are told is that they have to have an epidural to VBAC. Patients are often told this because doctors want an epidural on board in case they need to do a stat or emergency C-section in the event of a more catastrophic uterine rupture. However, many patients want to avoid as many interventions as possible during their TOLAC, as they may feel that a cascade of intervention is what led to their previous C-section. While it is true that a cesarean is safer with spinal or epidural anesthesia, the risk of needing a stat emergency C-section is actually quite low. Only 6% or less of ruptures are catastrophic, where the uterus fully opens up and doctors have only minutes to deliver the baby, which means when doctors force their patients to have epidurals to TOLAC, they are forcing over 2,000 women to have a medical procedure with all of its associated risks in order to prevent performing one cesarean under general anesthesia. That is simply not a reasonable policy. Another lie that patients may be told is that it is not possible to have a VBAC if you have had more than one C-section. It can even be extremely difficult to find a provider who's even willing to let their patients TOLAC if they have more than one C-section. And as a doctor who offers VBAC 2C or VBAC after more than one C-section, it can even be difficult for me to find other doctors who are willing to take care of my patients in the event that I am ill or have a vacation scheduled. And that's just because it's simply hard to find a doctor who's willing to take care of these patients. Why is this? Well, as you can tell, there is a lot of misinformation about VBAC that parades as fact, especially in the medical community, and especially when it comes to VBAC after more than one cesarean. Many doctors simply do not know that it is a safe, viable options for patients. For patients who have had two cesareans, the risk of uterine rupture has been shown to either be about the same as for patients with one cesarean or slightly higher at 0.7 to 1%. For patients with three or more cesareans, there's not enough evidence to really say what the risk of rupture is. However, the largest study done, which included about 240 patients, demonstrated a rupture rate of only 1.2%. So while it does appear that rupture risk increases with each subsequent C-section, there's not enough evidence to say by how much, and that risk must also be balanced against the much higher risk of complications with each subsequent cesarean. And that includes up to a 1% risk of hysterectomy at the time of their third C-section and up to 2% risk of hysterectomy in a fourth C-section. 1 in 130 moms will require a blood transfusion in their third C-section, and up to 1 in 63 will require a blood transfusion in their fourth C-section. In terms of VBAC success rates for moms with two previous cesareans, the success rates are as high as 75%. ACOG, again, is supportive to access to VBAC even with two or more cesareans, where it states that it is a reasonable option after two and states that it should not be considered contraindicated even after more than two cesareans. Providers and hospitals with anti-VBAC policies after more than one cesarean are simply outdated and, again, not following ACOG guidelines. So because of the amount of misinformation that women are often told when they're looking for a VBAC, and because of the mismanagement of TOLAC patients, women often look for other options. And this leads to lie number 9, which women seeking a different choice for their VBAC may hear, which is that it's just as safe to have a VBAC at home or in an out-of-hospital birthing center. So before I start talking about this, because I know I may make some of my audience mad, I do absolutely support a woman's right to birth in the place of her choosing with the provider of her choosing. And I myself offer out of hospital birth to my appropriate low risk patients. However, I think women are often misled about the safety of out of hospital TOLAC, and I do firmly believe that VBAC should be performed in hospitals. The evidence clearly shows that out of hospital TOLAC is not as safe as in hospital TOLAC in the United States. Home TOLACs are associated with an intrapartum, in labor, neonatal death rate of 2.9 in 1,000, in contrast to the 0.13 in 1,000 for planned hospital TOLAC. This means that your baby has a 22 times higher risk of dying in a home TOLAC versus a TOLAC performed in hospital. There are multiple likely reasons for this difference. The first is that strict low-risk selection criteria is less broadly applied in the United States than in other countries where home birth is well integrated into the maternal health care system. So we often see more just high-risk patients in general attempting home birth, and we often see more patients continuing in home birth or out of hospital birth in situations where they should have been transferred to hospital. Second, the fetal monitoring tools that are used by home birth providers or out of hospital birth centers are less likely to detect a uterine rupture than in hospital continuous fetal heart rate monitors. And when they do detect a uterine rupture, it is often more advanced. Third, there is no standardization of midwifery education and licensing in the United States, and there can be vast differences in the training, experience, and oversight of home birth midwives, and thus the quality of care can vary greatly between providers. Patients may or may not understand the level of training their provider has received. In contrast, in hospitals, while certainly not perfect, only board-certified obstetricians and CNM midwives are credentialed, guaranteeing patients that at least their providers have the required extensive amounts of education and training. Furthermore, while there are many states where it is actually illegal for home birth CPN midwives to offer VBAC, so those who do it are more likely to be rogue midwives or midwives who are more likely to skirt other safety guidelines or rules, or they may even be unlicensed, meaning there is no accountability or oversight in how they are practicing. Finally, in hospital, if an emergency occurs, all resources to respond to that emergency are immediately available. And that includes emergency access to anesthesia, cesarean, blood products, neonatal care providers, whereas in a home birth or birth center setting, there will always be a longer delay in care in the event of an emergency, which in the case of a uterine rupture can make a significant difference in the outcome for the baby. The final lie that patients are often told when they are exploring their options for VBAC is that a home birth or birth center midwife is just as likely to detect a uterine rupture as the hospital, and that they can get you to the hospital in time if this were to occur. So this is what many prospective home birth TOLACs are told in order to reassure them about the safety of VBAC at home. However, it's simply not true. According to the scientific literature, the most reliable sign of an impending uterine rupture is recurrent variable decelerations, which occur in approximately 70% of patients with a uterine rupture. Other clinical signs that would be something that a home birth midwife might detect, such as increase in pain, bleeding, changes in maternal vital signs, or loss of fetal station, they only occur about 30% of the time or less. Variable decelerations are decelerations that can occur at any time. They are variable, and that means they may occur with a contraction or they may not. Home birth midwives utilize intermittent auscultation, which means they listen to the baby's heart rate for roughly 3-minute intervals, and that's typically typically surrounding and during a contraction. And they are typically listening to that baby's heart rate every 15 to 30 minutes. That leaves a lot of time where a deceleration could be missed and could even possibly miss what we'd call a terminal bradycardia, which is where the baby's heart rate goes down and typically does not recover and usually will require an emergency C-section in under 30 minutes, but ideally within 15 minutes to avoid harm. Even if a home birth midwife recognizes a rupture immediately, has EMS immediately available, and an OR on standby for the arrival of the patient, it would typically take 30 minutes or more to get the patient into an OR and get that baby out. Even in a high-level hospital with full emergency resources at the ready and an excellent response time for staff, it is typically a 10-minute process from the time I call an emergency C-section to the point I'm pulling that baby out. Studies have shown that if a uterine rupture occurs, the longer the time from the diagnosis to delivery, the poorer the outcome. So when you just take into account all those factors, it just simply doesn't make sense to say that this is as safe of an option. And with that, I'll finish this video for today. I hope that I was able to debunk some common myths that you may have heard, and look for more information about VBAC or TOLAC in upcoming videos. Thanks, and have a great day.